Today, we are going to talk about the renal and urinary disorder. In this chapter, we will talk about the urinary function disorder and some terminology and pathophysiology of the disease. The first disease here is glomerulonephritis. So the picture you can see, this is the kidney, and this portion called pelvis, this is the pyramid, and this is calyx. So inside the kidney, we can get the nephron. One part of nephron is called glomeruli or glomerulus. So if any infection occur inside the glomeruli and it causes inflammation, the inflammation of glomerulonephritis or glomeruli, we call glomerulonephritis. So in this picture, we can see the first one is a normal glomerulus, and this one is a glomerulonephritis. So if you analyze this, the glomerulonephritis means inflammation of glomerulus. Glomerulonephritis is two types. One is called acute and another is called chronic. So first of all, we are going to talk what is the definition of glomerulonephritis. It is a term that refers to a group of kidney disorder characterized by inflammatory injuries in the glomeruli, and most of which are caused by an immunological reaction. So the patient who have glomerulonephritis, usually they give a history of infection like sore throat, impetigo, also it follows the staphylococcus infection or impetigo. And let me show you the picture. You see, this is the picture. This baby boy has an impetigo, and this baby girl came to the doctor for sore throat. So this is the infection, and particularly follow the staphylococcus infection. You see, the underlying cause of glomerulonephritis, immunological reaction, or autoimmune disease, or group A, beta hemolytic streptococcal infection, or pharyngitis or sore throat. So when this baby boy have an impetigo or this daughter has a sore throat, this organism, if untreated or maltreated, they go in the blood, and from the blood, they enter inside the kidney in glomerulus, and inside the kidney, antigen-antibody complex, antigen-antibody reaction occur, and that lead to antigen-antibody complex formation. This antigen-antibody complex reaction we call immunoglobulin reaction, or we call immunological disease. So glomerulonephritis, actually immunological disease. Unfortunately, if anybody has an autoimmune disease, means antibody produced automatically inside the body, and antigen antibody reaction occur. So they said usually the patient give the history of pharyngitis or tonsillitis 2 to 3 weeks before onset of the symptom of glomerulonephritis. So the basic symptom of glomerulonephritis are patient at the beginning come with headache, hematuria, weight gain, oliguria, proteinuria, or hypertension. Usually children may have periorbital edema. You see this baby boy, the edema inside the face and also around the eye, we call periorbital edema. Now let me go back and let me read it. The resulting proliferative and inflammatory change within the glomerular structure or destruction, inflammation, or clerosis of the glomeruli of both kidney occur, and loss of kidney function develop. So if infection will not cure, if glomerulonephritis treatment do not take enough, it leads to the kidney function loss. So inflammation of glomeruli result from an antigen antibody reaction. So when any bacteria get inside my body, means bacteria is a pathogen. Bacteria is an antigen. When antigen get in, it is the foreign body, and my immune system active and they produce antibody. Body can produce antibody, and antibody is a protein. Then antigen antibody reaction occurred, and it is immunological reaction and produced by infection elsewhere in the body. So here we see when patient has a glomerulonephritis, they can present proteinuria, means protein present in urine. Usually, protein does not passing through the kidney. It reabsorbs. But unfortunate patient or client who have glomerulonephritis, protein are allowed to pass out from the body, and protein present in urine we call proteinuria. And also the red blood cell are not allowed to go out through the kidney, but in case of glomerulonephritis, red blood cell go out and patient develop hematuria, means red blood cell present in urine. That types we said acute and chronic. Acute occur 2 to 3 weeks after Streptococcus infection, and chronic one may occur after the acute phase or slowly over the time. The sudden onset we call acute. Imagine a patient who have acute attack but does not treated enough or adequately. Doctor prescribed antibiotics. Patient did not take the antibiotic adequate doses, or patient did not complete the doses. Means the sign and symptoms subside, but infection still there, and it can continue and slow progressive damage to the renal cell slowly slowly over the time. And complication, kidney failure, hypertensive encephalopathy, seizure, pulmonary edema, and heart failure. Usually, the most common problem, hypertension or encephalopathy, or lead to the heart failure, pulmonary edema develop. Why seizure? Why encephalopathy? So our kidney is a function to excrete the nitrogenous waste product. When kidney does not work, the nitrogenous waste product accumulate in the body. They passing through the blood to the brain and impair the brain function. And also, what are the data collection? Patient has a periorbital or facial edema that is the most prominent in the morning. This picture has a periorbital and facial. So when fluid accumulate around the eye, we call periorbital. And this picture, water accumulate in the face, facial edema. Anorexia, decreased urinary output, or cloudy, smoky, brown color urine, or hematuria. So what are the treatment if baby boy have this? Usually we give diuretics or antihypertensive medication because complication is a hypertension. We give antibiotics. We tell patient for complete bed rest. Also low protein diet. This is the question NCLEX board asks. What food we prefer? Low protein diet. What are the other data collection? Patient pallor, irritabilities, and lethargy. In older child, headache, abdominal or trunk pain, and dysuria. Hypertension, proteinuria that produce a persistent and excessive foam in the urine, or azotemia, right? What is azotemia? Azotemia, it is increase the BUN, blood urea nitrogen, and creatinine, and suggests the renal impairment. Sometimes it is asymptomatic. So don't miss azotemia and uremia. Uremia is a full brown, and sign and symptom of renal failure is present in case of uremia, and decrease the calcium but increase the potassium in case of uremia. And also increase the blood urea nitrogen and creatinine level, increase stephylosin O titer, and it can confirm your patient as a infection. So used to diagnose the disorder caused by a Staphylococcus infection. What are the intervention? So we have monitored the vital sign. We monitor the daily weight because fluid retention, edema develop. So body weight will be increased. Strictly maintain intake and output, and also characteristics of urine. We have to check the urine, any blood or any pus, cloudy urine. And also measure daily weight at the same time of the day and during the same scale. And also patient supposed to wear the same clothes, limit the activities, and provide safety measure. NCLEX board asks a common question: what are the appropriate food for the patient, and what are the diet restriction? So sodium restriction depends on the stage and severity of the disease, especially the extent of edema. In addition, potassium may be restricted during the period of oliguria and low protein diet. Monitor for complication like kidney failure, hypertensive encephalopathy, seizure, pulmonary edema, or heart failure. So if our patient have a chronic glomerulonephritis, we can see it is in blood laboratory result of the blood examination, like increase of potassium, metabolic acidosis common, increase the creatinine, right? In case of chronic, I said, decrease the calcium, increase BUN level, or increase magnesium. Let me read first. Next intervention, assist to administer diuretics if significant edema and fluid overload are present. Antihypertensive because high blood pressure, and also antibiotics. The child with evidence of persistent staphylococci infection. Initiate the seizure precursor and assist to administer anticonvulsant as prescribed for seizure associated with hypertensive encephalopathy. And reinforce the instruction to the parents to report the sign of bloody urine, headache, or edema. Reinforce instruction to the parents that the child needs to obtain appropriate and adequate treatment for infection, and especially for sore throat, upper respiratory infection, or skin infection. Also, measuring the daily weight and monitor for weight change are the most useful and effective method to determining the fluid balance and determining the fluid retention or edema. Now we are going to talk about nephrotic syndrome, right? And here, what is nephrotic syndrome? It is usually follows another kidney disease. And most common sign and symptom we can see. So you see the picture number 1, nephrotic syndrome, baby picked before normal and after fluid, right? Facial edema. And this baby girl, periorbital and facial edema. And other sign and common sign symptom we can see proteinuria, massive proteinuria, hypoalbuminemia, and severe edema. Let me read it. A kidney disorder characterized by massive proteinuria, means too much protein expel out through the kidney and present in the urine. It is unlike in the healthy person, no protein in the urine. When protein go out from the body, so if you take my blood, you can get less protein in blood because most of the protein is getting out through the kidney because of nephrotic syndrome. So we can say proteinuria means protein present in urine, but hypoalbuminemia means hypoproteinemia. Hypoprotein, less protein in blood, less albumin in blood. Albumin is one form of protein, particularly small molecule of protein, amino acid. And when protein is out from my body, oncotic pressure change and edema develop. So NCLEX board asks question, which one is not a sign of nephrotic syndrome? So if you know which is a sign of nephrotic syndrome, you can easily find out which one is not a sign. What are the cardinal sign of nephrotic syndrome? I said proteinuria, hypoalbuminemia, and severe edema. The primary objectives of therapeutic management are to reduce the excretion of urinary protein, maintain protein-free urine, reduce edema, and prevent infection and minimize the complications. What are the data? The classic manifestation of nephrotic syndrome are this picture, right? We see proteinuria, hypoalbuminemia, and severe edema. Here we go, and flowchart. We can see in case of renal glomerular disease, patient develop proteinuria, means protein present in urine. When too much protein present in urine, blood protein will go down. So hypoproteinemia means blood less protein. And this lead to decrease the oncotic pressure. When oncotic pressure go down, edema develop. When oncotic pressure down, it lead to hypovolemia, means total volume in the body is go down. And when volume go down, decrease renal blood flow, kidney blood flow go down. When kidney do not get enough blood, they secrete renin, and renin causes vasoconstriction. And when blood vessel go vasoconstrict, blood pressure go up. Also, when hypovolemia occur, increase the secretion of ADH, antidiuretic hormone, and aldosterone. Sodium and water reabsorption, it lead to edema, it lead to the high blood pressure. And also hypoproteinemia causes increase the hepatic synthesis of more protein and lipid, and hyperlipidemia developed. What next? In case of nephrotic syndrome, child gain weight, periorbital and facial edema, most prominent in the morning, leg, ankle, labial or scrotal edema develop. Urine output decrease, urine dark or bloody, ascites develop, blood pressure normal or slightly decreased, lethargy, anorexia, and pallor, massive proteinuria, and decreased serum protein and elevated serum lipid level. What are the intervention? We could monitor the vital sign and strictly maintain input and output chart and daily body weight. We monitor the urine for specific gravity and protein. Also monitor the edema. Nutrition is very important for nephrotic syndrome baby. So a regular diet without added salt is prescribed if the child is in remission. Sodium is restricted during period of massive edema. Corticosteroid therapy prescribed as soon as diagnosis has been determined. Also, we monitor the child closely for sign of infection and other adverse effect of corticosteroid. Immunosuppression therapy may be prescribed to reduce the relapse rate and also reduce the long-term remission. Or if the child is unresponsive to steroid therapy, the therapy may be administered in conjunction with corticosteroid. What next? So in case of nephrotic syndrome, diuretics may be prescribed to reduce the edema. So diuretics is an antihypertensive medication, but we use here to reduce edema. Plasma expander such as salt 4 human albumin may be prescribed for severely edematous child. Reinforce instruction to the parents about testing the urine for protein, medication administration, the side and adverse effect of medication, also the general care of the child. Re-educate the instruction to the parents regarding the sign of infection and the need to avoid the contact with other children who may be infected. So now, another disease we are going to talk, it is hemolytic uremic syndrome. So what is the hemolytic uremic syndrome? So first of all, I want to show you a picture. So you see, this is the petechia, bleeding disorder, bruising petechia. So this is occurred because of one kind of organism, and this organism is called E. coli. E. coli, what type of E. coli? Is H7O1557. So if E. coli, this type, causes the infection, and they are responsible for hemolytic uremic syndrome. So here, so it is to be associated with bacterial toxin, chemicals, or virus that causes acute kidney injuries or acute kidney failure, right? So occurs primarily among the infants or a small children between the age 6 months to 5 years. So the peak incidence occur in this age group, and they can cause acute renal failure. The clinical features include hemolytic anemia, thrombocytopenia, kidney injuries, and central nervous system symptoms. Sometimes patients present with oliguria or diuresis, anyone. And also data collection, we call, there are 3 symptoms together, it's very close, triad of anemia, thrombocytopenia, and renal failure is the diagnostic. And proteinuria, hematuria, and presence of urinary crust. So patient present with anemia, hemoglobin go down, or platelet go down, thrombocytopenia, or renal failure. When renal failure occurs, may be present with proteinuria, may be present with hematuria, means urine mixed with blood, urine mixed with protein, or presence of urinary cast in urine. Even sometimes some patient present with oliguria, means urine production go down, or even sometimes patient will diuresis, too much urine. What else? Blood urinitis and serum creatinine level are elevated. So if we see the kidney function, we can say creatinine level go up, blood urea nitrogen go up, hemoglobin and hematocrit level are decreased. Here we go and say hemolytic uremic syndrome, most common cause of acute renal failure in the children. And you see this E. coli cigalite toxin, aerotoxin. They can cause abdominal pain, bloody diarrhea, fever, seizure, and lethargy. So red blood cell broken down and patient develop hemolytic, means red blood cell undergo lysis, hemolytic anemia. Also, platelet go less, thrombocytopenia or renal insufficiency. What are the treatment options? Mainly supportive dialysis, no antibiotics, or plasma pheresis is helpful. Now here, in case of hemolytic anemia, what are the manifestations? Sometimes patient present with vomiting, irritabilities, because waste product accumulate in your body. You will feel restlessness, lethargy, pallor because of anemia, hemorrhagic manifestation like bruising, petechia here, or jaundice, bloody diarrhea, oliguria or anuria, either scanty amount of urine or no urine at all. In anuria means absence. Central nervous system involvement and seizure, stupor or coma, very late states. Now, what are the intervention? So this cute boy has hemolytic anemia and need dialysis because of kidney failure. Hemolysis or peritoneal dialysis may be prescribed if the children is anuric, or strictly monitor of fluid balance is necessary. The fluid restriction may be prescribed if the child is anuric, or institute measure to prevent the infection, provide adequate nutrition. Other treatment may include medication to treat manifestation or administration of blood product to treat severe anemia. What next? Next topic here, we're going enuresis. It's refer to a condition in which a child is unable to control the bladder function, even though the child has reached an age at which control of bleeding is expected, or the child has successfully completed a bladder control program. By the age of 5, most children are aware of bladder fullness and are able to control the bleeding, right? So what in case of primary nocturnal enuresis, and this is, if you read this name, you can easily understand what it is. Nocturnal means at the night time, right? So at the night time, involuntary urination. Urination is our control. You call voluntary control. But if it is not your control, involuntary, especially by the children at the night time. So it is called nocturnal enuresis. And nocturnal enuresis can be due to the urinary tract infection, maybe. And this condition is common in children. Most children eventually outgrow the bedwetting without therapeutic intervention. What next? The primary nocturnal enuresis and secondary. The child is unable to sense a pool of bladder and does not awake wet. So eventually, bed is get wetting. The child may have delayed maturation of the central nervous system, or the child should be evaluated for any pathology causes before the diagnosis of primary nocturnal enuresis is made. The secondary, also called acquired enuresis, the onset of wetting occur after a period of established urinary continence. The secondary enuresis may occur during nighttime sleep, we call nocturnal, or only during the working hour or during daytimes and nighttime both. The child may complain of dysuria, urgency, or frequency. Means that they go for the pee or menstruation again and again. Frequency increase or urgency. They do not hold the urine. Before to go to the restroom, pee start, or desire or burning sensation, even dysuria. The child should be checked for urinary tract infection because urinary tract infection may the cause of enuresis. And for what are the data collection? History of patient give the history of parents give the history of bedwetting with no extended period of daytime in a child older than age of 5 years. What else? What are the intervention? So a urinalysis and urine culture may be prescribed to rule out infection or an existing disorder. Assist the family with identifying a treatment plan that is the best fit to needs of the child. Also limit the fluid intake at the night and encourage the child to void just before going to bed. So bladder training is helpful. Involve the child is caring for wet sheet or changing the bed to assist the child to take ownership of the problem. It is very effective. And what else? What next? Provide reward system is appropriate for the child. Incorporate behavioral conditioning techniques can helpful or medication. So what are the medication name can helpful? Like tricyclic antidepressant, antidiuretics, or antispasmodic is helpful. We use to treat enuresis. Also encourage the follow-up to determine the effectiveness of the treatment. And now we are going to talk about cryptorchidism. So what it is? So in this picture, we can see This is the testis, and this is the scrotum. Testis supposed to be inside the scrotum. It is the natural, but something you have to know. Testis, during the embryogenic phases, testis start to develop intra-abdominal. During the process of development, testis gradually descending from intra-abdomen through the inguinal canal to the scrotum. Sometimes, or unfortunately, if the scrotum does not descend to the, if unfortunately the testis does not descending into the scrotum, we call undescended testis. So one testis is descended inside the scrotum, we call descended testis. But if the testis did not descend to the scrotum and still in the abdomen or canal, internal inguinal canal, this one we call undescended testis. So when testis is undescended and causes some complication, this is called cryptorchidism. So cryptorchidism, it is a condition in which one or both of the testes is failed to descend from abdomen into the scrotum. So you see, occur when one or both testes fail to descend through the inguinal canal and into the scrotal sac. What are the data collection? Testis not palpable or easily guided into the scrotum. So if the healthcare provider palpate, they can feel no testis inside the scrotum, and it is called cryptorchidism. So what are the intervention? We could monitor during the first 12 months of life to determine whether spontaneously descend or not. So under the observation for first 12 months, after the age of 1 year, the medical and surgical treatment may be instituted, means we follow medical or surgical management. The human chorionic gonadotropin, or a pituitary hormone that stimulates the production of testosterone. And testosterone may be prescribed for an older child. The surgical correlation or surgical correction, if needed, is performed by orchioplegy before the child's second birthday. If the testes do not descend spontaneously, right? But if you ask me what happened if the cryptorchidism is not treated, if not treated, this might result in the loss of testes, or testicular torsion occur 10 times more often in undescended testes that is normal than the normal testes. And what next? Surgical correction, if needed, is performed by orchioplegy before the child's second birthday. Monitor for bleeding and infection post-operatively. re-educate instruction to the parents regarding post-operative home care measure include preventing infection, pain control, and activity restriction. Provide an opportunistic for parental counseling if the parents are concerned about the future fertility of the child. So the good counseling is important, right? So what next? Next, we are going to two keyword or terminology. One is called Epispadias and Hypospadias. So Epispadias or Hypospadias, congenital defect that is involved the abnormal placement of urethral orifice of the penis. And this anatomical defect can lead to easy entry of bacteria into the urine. So this is the picture we can see. This is the scrotum, this is penis, and this is the tip of the penis we call glans penis. So when you call epispadias and when you call hypospadias. So this is the orifice or orifice of urethra. It's supposed to be the tip of the penis, but unfortunately it is present in the dorsal surface. So dorsal placement of urethral opening is called epispadiasis. If the urethral opening in the ventral surface, it is called hypospadiasis. So if the opening in dorsal surface or ventral surface, they easily get infected by urinary tract infection. And urinary tract infection, if not treated, I mean UTI, if UTI is not treated, from here it is go to the retro direction and patient develop the cystitis, means urinary bladder inflammation, cystitis, urethritis, or nephritis, pyelonephritis, and causes the kidney infection. So it is good to surgically correction and prevent the infection. So epispadiasis or hypospadiasis are genital anomalies in which the urethral opening is above or below its normal location on the glans of penis. So data collection, epispadiasis urethral orifice is located on the dorsal surface of the penis, often occur with exstrophy of the bladder. So if the bladder is not inside the body, we call exstrophy. And hypospadiasis urethral orifice is located below the glans penis and along the ventral surface. Both of it can possible to correct surgically. So what are the surgical intervention performed before the age of toilet training, or preferably between 16 and 18 months of age? So before 2 years of age, it is good to go for surgical management. Circumcision is not performed on a newborn who have Epispadias or Hypospadias. Although there are other surgical techniques used to repair this defect, the pediatrician may prefer using a foreskin for surgical reconstruction of the defect. So the glans penis is covered by skin. It is called foreskin. During the circumcision, the pediatrician removed the skin, but this skin they can use to reconstruct the epispadias or hypospadias. So what are the post-operative intervention? The child will have a pressure dressing and may have some type of urinary diversion or urinary stent while the meatus is healing. We monitor the vital sign. We encouraging fluid intake to maintain adequate urine output and to maintain the patency of the stent. We strictly monitor import and output and the urine for cloudiness or a foul odor. We notify the registered nurse if there is no urinary drainage for 1 hour, because this may indicate kinking or bending or blocking in the system or obstruction by sediment. Also assist to provide the pain medication and medication to relieve the bladder spasm is prescribed. So what are the what next? Next, postoperative assist to administer antibiotics, reinforce the instruction to the parents regarding the care of the urinary diversion or stent, reinforce instruction to the parents to avoid giving the child a tub bath until the stent. Also reinforce the instruction to the parents about the food intake, medication administration, and the sign and symptom of infection. And also the need for healthcare provider follow-up for dressing, removal approximately 4 days after surgery. So after 4 days, we can remove the dressing. The next terminology here, it is called bladder exstrophy. What is bladder exstrophy? Bladder exstrophy is a congenital anomaly characterized by extraction of the urinary bladder to the outside of the body through a defect in the lower abdominal wall. So this is the picture. The urinary bladder is supposed to inside our body. But if the baby born and bladder you can see outside, this is the defect, right? When bladder is outside, we call bladder exstrophy. The cause is unknown. The treatment requires surgical management and occur in a series of stage reconstruction. Yet initially, surgery for the closure of abdominal defect is normally planned within the first few days of life. The goal of subsequent surgeries are to reconstruct the bladder and genitalia and also enable the child to achieve that urinary continence. So what are the signs and symptoms we see if baby born with this defect? Usually exposed bladder mucosa, also pubis symphysis. So this area we can see extra folded, also defect the external genitalia, defective. Intervention. So it is possible surgical management. So monitor the urine output, monitor the sign of urinary bladder and wound infection. Maintain the integrity of the exposure bladder mucosa. Prevent the bladder tissue from dying while allowing for drainage of urine until surgical closure is performed. Immediately after birth, we always, after birth, we will allow the drainage of urine. Also, exposed the bladder is covered with a sterile, non-adherence dressing to protect it until closure can performed. What else? The laboratory velos and urinalysis are mentioned to assist for the kidney function. Assist to administer antibiotics, provide emotional support to the parents, or encouraging verbalize their feelings, their fear, and their concern. Applying the petroleum jelly to the bladder mucosa is avoided. Why? Because it tends to dry out and adhere the bladder mucosa and damage the delicate tissue when dressing is removed. So up to this, pediatrics, nephrology or urinary disorder.